Welcome. Good afternoon. We're excited to have another series of patient case discussions today. My name is Suresh Ramalingam. I'm a thoracic oncologist at Emory University's Winship Cancer Institute. And today I'm joined by a fantastic panel of multidisciplinary experts focused on thoracic oncology. And I'm going to allow them to introduce themselves. First, let me start with Dr. Michelle Ginsberg.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Imaging and Vice Chair for Education at Memorial Sloan Kettering Cancer Center, and also Professor of Radiology at Weill Cornell Medical College.
Hello, I'm Dr. Seth Force. I am the Kamal A. Mansour Professor of Surgery and Chief of General Thoracic Surgery at Emory University Hospital in Atlanta, Georgia.
Hi, thank you, and good day. My name is Dr. Wally Curran. I'm a radiation oncologist and the Global Chief Medical Officer of Genesis Care and Professor Emeritus at Emory University.
Hello, and good afternoon. I'm Tom Stinchcomb. I'm a thoracic oncologist at Duke Cancer Institute.
We're going to go over some very exciting cases. We have a wide array of cases today that represent important clinical considerations and contexts that we face in our clinic. Our next case is a 50-year-old woman who has poorly differentiated thymic carcinoma, and we're going to talk about management of recurrent disease. But before that, we will also talk about the primary treatment of the situation. So this patient presented with facial swelling, difficulty swallowing liquids, and also had some headaches. Prior to that, the patient has an ECOG performance status of 1. The past medical history is significant for hypertension. The patient does not have history of tobacco smoking or alcohol use. The family history does not have any salient findings. So these are the imaging studies. Let me invite Dr. Ginsberg to interpret the CT scans for us.
We have a large anterior mediastinal mass, which measures up to almost 13 centimeters in largest diameter, and probably even more in the longest axis on the sagittal image. The mass is invading the mediastinum. We have loss of the fat plane and also compressing the superior vena cava. There is also extension into the paratracheal region, and you see on the lateral view that this mass is indeed compressing the superior vena cava and extending inferiorly up to and probably invading the pericardium.
Thank you, Dr. Ginsberg. So, Dr. Force, you're often the first one that's called when there is a patient like this in the emergency department or from the primary care physician's office. Talk to us a little bit about how do you approach the diagnosis of this anterior mediastinal mass?
Sure, Dr. Ramalingam. So we know that the two most common anterior mediastinal masses that present in terms of malignancies are thymomas and lymphomas, and certainly thymomas are the predominant in adults. When we see something like this, we obviously know we need a biopsy. And the considerations with biopsying these masses are twofold. Number one, with large masses that have compression of the cardiovascular structures and the airway, intraoperative biopsies with general anesthetic can often bring on cardiovascular and pulmonary collapse, especially if there's a lot of mass effect. Secondarily, we don't like to biopsy these through a thoracoscopic approach because even if it's stage 3 or stage 2, you will see the pleural space and often make this a stage 4 cancer. So typically for mass this size, we recommend a CT-guided core needle biopsy. That's not very effective for lymphoma. It's hard to diagnose lymphomas with needle biopsies, but thymomas and thymic carcinomas should be pretty easy to biopsy with a CT-guided core needle biopsy. If that is non-diagnostic, then a kind of classic procedure called an anterior mediastinoscopy or Chamberlain procedure is performed, where we basically go between the second and third rib on whichever side the lesion's on. In the classic model, you took out the costal cartilage, but that's kind of morbid. But we stay in the mediastinum and biopsy this thing, and we don't ever breach the pleura, and so that we avoid seeding the pleural space with that tumor.
So as you talk about CT-guided core biopsy, is there a concern for tumor growing along the track of the biopsy or not? I mean, I know this comes up in tumor board discussions.
I mean, there's always a concern with any needle biopsy of any type tumor that you could see the tract. I think that, when you look at lung cancer, when you look at mediastinal masses, that incidence is very low. In my experience, it's been higher when the needle goes through a major muscle, like through a pec or a or latissimus, a thick muscle. It seems like that the tumor can get scraped off. But the incidence of that is incredibly low. And the reality is we need there's no way to get a biopsy without breaching the soft tissues, whether it's an open surgical biopsy or a CT guided biopsy. And for whatever reason, the incidence of those biopsy site recurrences is low. And often patients like this are going to get radiation at some point anyway. And if there's concern of that can be included in the radiation field. But that's not really a concern of ours.
Thank you. So this patient ended up getting a VATS procedure with a biopsy. And this biopsy revealed the diagnosis of thymic carcinoma, which was poorly differentiated. And you can see the positivity for P63 and CAM5.2. So we have a patient who is very symptomatic from thymic carcinoma. Let's talk about the role of surgery in this situation to start with, Dr. Force. Is this somebody you would consider surgically resectable?
Well, so, I mean, it's hard to see from these limited images. I mean, with thymic tumors, what really makes patients unresectable is involvement of major vascular structures. And I can't tell that on these limited pictures. Certainly to me, and Dr. Ginsberg can comment, it looks like there's a plane between that ascending aorta and the tumor, but I can't see the full pulmonary artery. I mean, oftentimes it might be resection and a pneumonectomy. So it's hard to tell from these images, but from these images alone, we would say not necessarily. We know the thymic carcinomas do not do as well as the thymomas, and particularly the thymic adenocarcinomas. So, in a thymic adenocarcinoma that's advanced stage, you start putting things together with a big operation, maybe not, but it really comes down to getting negative margins. And I can't tell from this picture alone, whether we could get the whole thing out or not, and what the margins would look like.
So I agree. We often can't tell on imaging whether there's a true fat plane or looks like a fat plane, and eventually the only way to answer it is surgically.
Dr. Ginsberg, would an MRI of the chest provide any additional information in this situation?
It may add some information, but again, the same issues could occur with MR as well. You can't totally tell that there is that fat plane and whether you could just peel it off or if it's truly invading.
I do think that if surgery was going to be offered, because it does seem to be at least stage 3 based on the lymphadenopathy, it would not be the first treatment that we would offer. The patient would need some type of neoadjuvant therapy if we were going to consider surgery.
Thank you. So this patient was evaluated by a cardiothoracic surgery team and was deemed unresectable due to the proximity to the superior vena cava. And then the patient proceeded to receive concurrent chemoradiation. So why don't we start with Dr. Curran to talk about the role of radiation in this, and then we'll get Dr. Stinchcomb to comment on systemic therapy.
Yeah, so thanks, Dr. Ramalingam. So thymic cancers are rare and have to be defined by specific tumor markers to distinguish them from a very aggressive non-small cell lung cancer invading the mediastinum. In a series of thymic tumors that I reviewed and published on years ago, we found that some of the cases that were initially classified as very aggressive thymomas, in retrospect, were thymic carcinomas and did fairly poorly. When we grouped a series of thymic carcinoma patients together who received radiation or chemoradiation, their outcome was not particularly different than patients with unresected non-small cell lung cancer of a stage 3 type. The difference tended to be that they had more bulky central disease, as does this patient, and therefore the likelihood of long-term control with chemoradiation alone is low. There hasn't been enough studies to say whether on a volume basis, patients with thymic carcinomas do more poorly than non-small cell. But it's my clinical impression that because they're bulky, they tend to do poorly and tend to be less kind of treatment sensitive than certain subtypes of non-small cell lung cancer.
Thank you. So, Dr. Stinchcomb, what are your thoughts on systemic therapy for this patient? What regimens would you choose, and what schedule of these agents would you use for administration?
So in this patient, I think the carbotaxol and radiation therapy is sort of the very standard approach that we've used, largely extrapolation from non-small cell lung cancer. And I've generally, this is an extrapolation given the rarity of thymic carcinoma, used RTOG0617 approach for chemoradiation. And I've done the weekly carbotaxol, and if patients in a good fit, I would then do the 2 cycles of consolidation just to follow that paradigm.
Okay. Dr. Curran, the dose of radiation for thymic, is it more or less the same as what we would use for non-small cell lung cancer, or?
Yeah, probably. The caveat is for bulky central disease, such as this patient has, your dose limitations are probably going to come from cardiac dose, probably cardiac toxicity is your greatest risk with management of bulky thymic tumors. We do have the tools to look at, what is the dose of to the heart. And, this is the kind of patient where perhaps a proton therapy plan could be compared against an IMRT plan. The advantage of the way radiation oncology treatment systems work is there are systems where you can simulate what a proton therapy plan would look like as compared to a non-proton plan. So it doesn't, the same dosimetry and physician team at some centers could really look at that and give feedback to determine whether the cardiac dose is meaningfully reduced by using proton therapy.
Now, this patient was deemed unresectable at the get-go, but if we were dealing with a scenario where the surgeon said, well, we can't resect right now, but perhaps after chemoradiation, we would consider resecting, would that change the radiation approach in terms of how much dose you would give?
You'd probably give a lower dose. You'd probably give 50 rather than 60 gray if it was anticipated to be a preoperative approach. If you were talking about postoperative approach, it really depends on the details of the surgery and whether there was a complete resection or not.
And Dr. Force, what sort of surgery or how straightforward or complicated is a surgery after chemoradiation versus doing it up front? What are the special considerations there?
I mean, there can often be what we call a desmoplastic response of the tumor to that combined chemotherapy and radiation, where the tissue planes become, somewhat less clear, and we don't know if that's from tumor or just the inflammation from the chemotherapy and radiation. Setting aside the fact that it looks like this patient has at least stage 3 cancer, involvement of the superior vena cava alone does not, in my mind, make the patient unresectable. It's not uncommon that we have to sacrifice the innominate vein or reconstruct the superior vena cava with these large tumors. And while that's more complicated, there's a reasonable approach. That's different than the tumor growing into the ascending aorta, which is a completely different risk, huge operation, which in my mind would make that patient unresectable. So, one theoretical option and not just getting the tumor out, but reducing the radiation kind of burden would be to give neoadjuvant chemotherapy followed by resection, even reconstruction of the superior vena cava, and then adjuvant radiation therapy. And I don't think that that's unreasonable. And sometimes you get in there and you don't have to remove any of the cava. Sometimes you just have to patch it, or you can even replace and reconstruct the whole thing. And you're also hopefully avoiding, patients developing superior vena cava syndrome down the road, which is a pretty morbid thing for them. So for tumors like this, I would prefer, adjuvant radiation, but chemoradiation neoadjuvant doesn't make the patient unresectable either.
Thank you. So this patient received 60 gray in 30 fractions as definitive radiotherapy along with weekly doses of carboplatin and paclitaxel. The patient was again seen by thoracic surgery team and was when it was decided that this tumor continues to remain unresectable. There are some images here. Perhaps Dr. Ginsberg can comment on what do you think is the response this patient has had to chemo and radiation, since these are post-treatment images.
Right, so it looks like the mass has responded and has decreased, but it still remains like a large mass that's inseparable from that superior vena cava.
Okay, so that's positive. And this patient, as Dr. Stinchcomb had alluded to earlier, received 2 cycles of full dose carboplatin paclitaxel. And within a few months, about 8 months to be precise, after this treatment, the patient's PET CT scan has some new findings. And let me ask Dr. Ginsberg to comment on that.
So we see that there's an avid supraclavicular lymph node, which was subsequently, I see biopsied and turned out to be metastatic disease from the thymic carcinoma.
Thank you. So it sounds like this is the only site of progression. And that brings up the question, Dr. Curran, whether this is something that can still be subjected to local therapy, or is prior radiation in this area going to be a problem for this patient?
Given the volume and the focality of it, it could be treated with a regimen where you really, the big challenge is making sure the brachial plexus is not given too much dose, recreating the dose from the prior plans. But if it's truly a solitary area of progression, I think that's very reasonable.
Dr. Stinchcomb, what would considerations for systemic therapy look like for this patient?
So assuming that local therapies are not an option, or I think that there's several different therapies that can be used. I've generally used single agent immunotherapy in this situation with a response rate of about 20%. There is some concern that there could be a high rate of myocarditis was observed in one of the studies. So that's a very unique toxicity related to this patient population to be aware of. Other options could be sunitinib has been studied, single agent pemetrexed has been studied, and other single agent chemotherapy options. But I would recommend single agent pembrolizumab because that's the agent that was used in those phase 2 studies.
What sort of response data are observed with single agent immunotherapy in this situation, Dr. Stinchcomb?
Thank you, Dr. Ramlin. Response rate is about 20 to 25%. And so the response rate is not as high. And then if you kind of look at the duration of response or the progression-free survival, they're not as robust. So I think that what the exact role of immunotherapy in this disease still needs to be better defined.
Now, for patients with thymoma, there is some concern that using immune checkpoint inhibition could result in excess toxicity. So we don't have to think about that as a concern here in thymic carcinoma, is what I'm interpreting your recommendation to immunotherapy as. Is that fair?
That's fair. And then you obviously will make a check to make sure there's not any underlying autoimmune diseases, as you would do with any patient receiving immunotherapy. But okay, there's not a higher rate with thymic carcinoma the way there has been an association with thymoma.
So still relatively low response rates with systemic therapy, especially in a setting where the patient has progressed after prior chemotherapy, which would bring up the point which Dr. Curran mentioned. If radiation can be done for this, that would be our preferred recommendation for this particular patient, correct?
That's correct. I mean, as you correctly stated, the response rates are very low and they're not very durable. So I think that we'd like to use local therapies whenever possible and reserve systemic therapy for more diffuse disease progression.
Great. And Dr. Curran, as you talked about proton therapy, perhaps as we wrap up, if you can tell us a little bit about what's the current use of proton therapy for thoracic malignancies? What situation should we consider beyond this patient scenario?
Sure. So proton therapy has been studied for patients with stage 3 non-small cell lung cancer. There have been studies at MD Anderson, Mass General, which have given variable results. But right now, there is a phase 3 trial being done in energy oncology, comparing a standard regimen of 60 gray with concurrent chemo versus a proton regimen of a slightly higher dose. And that's, I think that's about 2/3 enrolled. So we will get a signal from that. Proton therapy is interesting because one way I think of it is as just another tool in the radiation oncologist toolbox. That there wouldn't necessarily need to be a defined indication, but you should have a strong enough multidisciplinary team within radiation oncology of dosimetry, physics, physician, working with the thoracic multidisciplinary team to say, in this particular patient's case, the dose reduction to the lungs, to the heart, to the spine with our proton tool is superior to IMRT or 3D radiation. So we would recommend that. I don't think proton therapy is necessary for every patient, but there are good case studies of lots of patients where the plan is just superior and should be used with discretion when appropriate.
Great, thank you so much. So for this patient, the panel recommends using local radiation therapy for the supraclavicular lymph node and withholding systemic therapy for potentially a future situation, which unfortunately is more likely than not.